So the first exemplar we're going to talk about is erectile dysfunction. So just by definition, it's the inability of a male to attain and maintain an erection sufficient to permit mutually satisfactory sexual intercourse with the partner. That's quite the definition. Most of us know what erectile dysfunction is. There's quite a bit of press over the last 20 years that have been focused on that. So it's a topic we hear about a lot more often these days. I will kind of bring some attention to the fact that it's mutually satisfactory. So you may have an individual with erectile dysfunction or having issues with erections, but if they are not bothered by it, then it's not necessarily a problem for them. So not every patient that has that issue is going to want to be treated or needs to be treated. So it's going to be dependent upon that partner and the patient and what they are desiring at the time. It's very common. About 30 million American men are going to experience it at some point in their lifetime. And those that are over 75 years of age, about 47% of those men are going to experience some sort of erectile dysfunction at some point in their life. It's not inevitable. It's not, it used to be viewed for years that as a man aged, that's what was going to happen. That was the natural progression. It's no longer that way. We have treatments and we can be proactive at assisting that individual. There are chronic ED, intermittent ED, and episodic ED. Your textbook goes into some of those and what that means. But just because a man has erectile dysfunction at some point does not mean it's with every sexual encounter every time. Sometimes that differs. Some men will have libido changes, so they may have a decrease in libido, but some do not. They may still have that increased sex drive, but they just cannot perform as they like. So those do not always go together. It is a multifaceted issue, just like sexuality in general. So there are some psychological issues. We talked a minute about a man that's widowed. His whole life has been changed, and now he's in a new environment, and that can certainly impact that. There are some physical issues, spinal cord injuries, diabetes that we talked about last semester with the micro and macrovascular changes are a huge issue for ED, one of the common reasons. Cardiac issues as well, prostate surgery, prostate cancer, all of those can lead to erectile dysfunction. And then medications are another big one. One of the huge ones that you'll see that really impact ED are the selective serotonin reuptake inhibitors. So your Zolofts, your Paxils, Prozac, which we know lots of patients are on. Depression can also create erectile dysfunction under that psychological aspect. So you may have an individual come in and they are depressed, so they're already having some ED issues or decreased libido issues, and then now we're going to put them on an SSRI, and that they think may improve their sex life because they're feeling better, and they may in fact be having some other issues related to those medications. So sometimes it takes medication changes, dosage changes, sometimes it gets better with time. And so we just have to teach those patients when we start giving them those SSRIs that that's one of the side effects for them to consider that. So when a patient comes in, we really need to drill down and find out why they are experiencing erectile dysfunction. Do they have a chronic medical condition we don't know about? Are they taking some sort of medications that are creating this issue? So you're going to see them get some standard blood work, so a complete blood count or CBC, just to kind of overall look at their health. A lot of times they're going to get a PSA or a prostate-specific antigen, which looks for potential for prostate cancer. So is this a prostate issue that we have that's causing problems? Low testosterone levels also can cause ED, so they will typically draw a testosterone level as well to see. If all of those come back normal and we still have not identified the issue, then a lot of times these patients are sent for blood flow studies, and it's exactly what it sounds like. We're going to do a test to see how those vascular system within the penile organ is actually working and seeing if there's any occlusions that are preventing that patient from achieving an erection. So there's some medications that they may be prescribed. So phosphodiesterase type 5 inhibitors. So these are the Viagra, Cialis type medications that you're probably very familiar with if you've watched TV in the last 20 years. There are some risks associated with this, and they are not appropriate for every patient, particularly if they have cardiac issues. So take a look at those when you start looking at your medications. Make sure you pay attention to that. There are some injectable medications. They are typically a little older, that were more commonly used before the phosphodiesterase inhibitors were created. Some patients will still use those, but they are actually injected into the base of the penis. So many men are not super excited to do that, and I can't really blame them. Hormone replacement can be an option if they have hormone issues that are causing the ED, so low testosterone in particular. There are some mechanical devices that you may see used. These are typically older as well and used before the medications came about. So things like vacuum devices, O-rings are available. There are other kind of names that you've probably heard called, but this is the medical name for those devices. And then there are penile implants too as well, which help. This is my favorite. Every year when we get to talk about this, I love this. So I believe if Cialis really worked, that couple should be in the same bathtub. I would think that would be true. Yeah. Great ad campaign, I guess, but it is odd that they are in two different